1, 2,
And review 70-year-old female.
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
Let's start with
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. What are the echo people check? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, when you first start studying the human body, there's this, like, comforting expectation of precision.
Right, yeah, like it's all mapped out.
Exactly. It feels like engineering. Like you break your arm, the x-ray shows a jagged white line on a black background, and the doctor just points at it and says, you know, there it is. That's the problem.
Yeah, it's a very binary world.
Right. Broken or not broken. You cast it, it heals, you move on.
It is. It's highly visible, easily categorized, and, well, deeply comforting to the analytical mind. We really crave that kind of diagnostic certainty.
But then, you know, you step onto the labor and delivery floor, you dive into the world of obstetric nursing and high-risk pregnancies, and suddenly that metaphorical x-ray machine is just, like, completely shattered.
Oh, absolutely. It's gone.
You're looking at a diagnostic landscape that is, quite honestly, incredibly murky. I mean, you aren't dealing with one patient, you're dealing with two simultaneously.
Right, two entirely different physiological systems.
Yeah, and the changes are completely dynamic, like constantly shifting hour by hour, and they're just a million overlapping variables.
It is the absolute definition of diagnostic muddy waters. And if you are studying for your nursing exams right now, if you're, you know, staring down the NCLEX or your final maternal child health exams trying to navigate those muddy waters can feel entirely overwhelming.
Oh, well, for sure.
You're looking at a textbook that is 1,000 pages long, wondering how to possibly memorize every single obscure syndrome.
Which is exactly why we're doing this today. So welcome to a highly specialized, intensely focused deep dive.
Yeah, we're so glad you're here.
If you're listening to this right now, we know exactly what your mission is. You are out to conquer obstetric nursing. Your goal isn't just to, like, pass a test. Your goal is to walk onto a clinical floor with the sharpest possible clinical judgment and be a safe, effective, and frankly phenomenal future nurse.
And my role today is to be your clinical mentor. We're not going to sit here and read a textbook table of contents to you.
Please no.
Right. We are going to aggressively apply the Pareto principle to this material.
So for our listener who might be, you know, buried in flashcards right now, let's establish what applying the Pareto principle actually looks like for an OB nursing student.
Well, it basically means we acknowledge a very practical reality. Like 80% of your exam points, and honestly, far more importantly, 80% of your most critical, life-saving clinical interventions, they come from just 20% of the core concepts.
Wow. Just 20%.
Yeah. So we've sifted through a massive mountain of obstetric data, maternal risk factors, fetal surveillance guidelines, all those prenatal testing protocols. And our singular goal today is to extract that high-yield 20%.
That is so helpful.
Everything we discuss is going to be filtered through a very specific, uncompromising lens. We're looking at maternal and fetal safety, priority nursing interventions, and the classic traps that exam writers just love to set.
I love that approach. The mission is to take these raw, isolated medical facts and forge them into clinical judgment. Like, we need to help you instantly separate the this is an expected annoying part of pregnancy finding from the I need to hit the call bell and report this immediately scenario.
Exactly. That distinction is everything.
So let's start by unpacking the absolute highest risk elements of a pregnancy. Because to really understand how things go wrong, we have to look at the giants. The two biggest, most pervasive culprits that damage the placenta and threaten both patients.
And those are hyperglycemia and hypertension, blood sugar and blood pressure.
These are the heavy hitters.
They really are. I always tell students, if you fundamentally understand how these two chronic conditions alter the physiological landscape of a pregnancy, you will be able to answer countless exam questions without even needing to memorize them.
Oh, that's a great tip.
Because, you know, these two forces dictate placental perfusion, and placental perfusion dictates fetal survival.
Okay, let me try out an analogy I use to visualize this, and you tell me if the clinical physiology actually holds up.
All right, let's hear it.
So I like to think of the placenta as this incredibly delicate, a highly vital filter and like life support system for the baby.
Yeah, perfect so far.
High blood pressure acts like a kinked high-pressure garden hose. It restricts the flow of blood, effectively starving the baby of oxygen and nutrients. On the flip side, high blood sugar acts like a thick, heavy sludge, clogging up that delicate filter, and it ends up forcefully overfeeding the baby with excess glucose.
I mean, that is a phenomenal visual, and it aligns perfectly with the high-yield core concepts you need to master. Let's look at the thick sludge, first hyperglycemia.
Okay, let's get into it.
So whether a pregnant client has poorly managed pre-existing diabetes or they develop gestational diabetes, the core issue is maternal insulin resistance leading to elevated blood glucose. Now, here is the crucial physiological mechanism, right? This extra maternal glucose crosses the placenta to the fetus through a process called facilitated diffusion.
Right, the sugar crosses over freely, but the maternal insulin does not cross the placenta, correct?
Exactly, and that is a massive foundational concept. Glucose crosses the barrier, but the large insulin molecule does not. So picture the fetus.
Okay, I'm picturing it.
The fetus is suddenly receiving all this excess sugar from the mother, but it has no maternal insulin to help process it.
Sure.
What happens? The fetal pancreas has to work overtime. It hypertrophies or, grows larger to produce its own massive amounts of insulin just to handle the mother's sugar.
Wow.
And here's the kicker. Fetal insulin acts as a very powerful growth hormone.
Ah, so that directly leads to our first major complication, which is fetal macrosomia.
Precisely. Macrosomia literally translates to large body. We were talking about a significantly huge baby, often over 4,000 or 4,500 grams.
Which obviously cascades into a whole host of other intrapartum risks. I mean, if you have a massive baby, you have a significantly higher risk for a cesarean birth. Or, if a vaginal birth is attempted, catastrophic birth trauma like shoulder dystocia.
Right. Where the baby's head delivers, but the broad shoulders get stuck behind the maternal pubic bone. It's a terrifying emergency.
Yeah, absolutely terrifying.
But the hyperglycemia doesn't just make the baby large, it alters the environment itself. It causes polyhydramnios, which is an excessive accumulation of amniotic fluid.
Okay, wait. I understand why the baby gets big, right? Because insulin is a growth hormone. But why does the mother's high blood sugar cause the amniotic fluid to increase? Like, does the sugar just pull water into the sac osmotically?
That is a very common misconception. It's actually driven by the fetus.
Really?
Yeah. Because the fetus is experiencing hyperglycemia, its own blood sugar is too high, the fetal kidneys try to flush out that excess sugar. The fetus experiences polyuria.
Oh, wow.
Basically, the fetus is peeing excessively into the amniotic sac. Since amniotic fluid in the second half of pregnancy is primarily composed of fetal urine, excessive fetal urination directly equals polyhydramnios.
That is fascinating. So the high sugar leads to a big baby and literally a swimming pool of excess fluid.
Exactly.
Now, let's look at the kinked hose hypertension. Whether we're dealing with chronic hypertension or pregnancy-induced hypertension, what is the high-yield takeaway for the exams?
So hypertension fundamentally damages the maternal vasculature. It causes vasoconstriction and damages the endothelial lining of the blood vessels, particularly the spiral arteries that feed the placenta.
Okay, so making them narrower and stiffer?
Right. This increases peripheral vascular resistance and directly causes uteroplacental insufficiency. The placenta is simply not receiving enough oxygenated blood.
And if the placenta isn't getting blood, the baby isn't getting fed.
Exactly. Because the fetus is essentially being starved of resources over a long period, it leads to fetal growth restriction. This results in a baby that is small for gestational age, or SGA.
Oh, that's a perfect contrast.
Yeah, so right there, you have a beautiful contrast for an exam. Diabetes gives you macrosomia, large baby. Hypertension gives you SGA, small baby.
Makes total sense.
Furthermore, hypertension can worsen into a terrifying systemic condition called preeclampsia, and if left untreated, it progresses to eclampsia.
And eclampsia means seizures, which is a life-threatening emergency that can easily lead to maternal and fetal death.
It is the ultimate nightmare scenario on a labor floor. Preeclampsia severely limits placental perfusion, but it also causes multi-organ damage in the mother. I mean, it damages the kidneys, the liver, and the brain.
So as the nurse at the bedside or, taking vitals in the prenatal clinic, how do we differentiate between an expected annoying pregnancy symptom and a life-threatening preeclampsia red flag? Because let's be honest, pregnant clients get swollen ankles all the time.
Yes, they do. And that is a critical distinction for your clinical judgment. If a patient comes in at 34 weeks and says, "My shoes don't fit," you need to investigate further, but don't panic. Mild, dependent ankle edema from standing all day where the fluid pools in the lowest part of the body due to gravity and the heavy uterus pressing on pelvic veins is an expected biophysical change. It's totally normal.
So when does that puffiness become a priority report?
When the edema stops being dependent and becomes systemic. If you see sudden facial edema, a client says, "My eyelids are puffy and I can't get my wedding ring off my hand." That is concerning.
Okay, systemic is bad.
Right. But the true red flags that elevate this to an immediate crisis are when you see protein in the urine, known as proteinuria, or when the client reports sudden, severe headaches, visual disturbances like seeing spots or flashing lights, or severe pain in their upper right abdomen.
Let's break down the why there. Why are headaches and vision changes such a massive, glaring red flag on an NCLEX exam?
Because they indicate that the hypertension has compromised the blood-brain barrier. They indicate cerebral edema and profound central nervous system irritability.
The brain is swelling.
The brain is literally swelling and becoming hyperreactive.
Yeah.
When a preeclamptic patient reports a severe headache that won't go away with Tylenol or changes in their vision, it means they are teetering on the edge of a seizure. Those symptoms require an immediate report to the provider. You do not wait. You do not reevaluate in an hour. You act.
Priority nursing actions are huge on these exams. What is the nurse doing to catch this cascade early?
Your baseline defense is consistent assessment. At every single prenatal visit, without fail, you assess the maternal blood pressure and you perform a urine dipstick. You are looking for protein, which indicates kidney damage from preeclampsia, and glucose, which indicates uncontrolled diabetes.
Okay, let's pivot back to the diabetic mother for a moment, because here is where the pathophysiology gets incredibly interesting, and this is without a doubt a top exam trap.
Oh yeah, the sugar drop.
Exactly. Let's call it the sugar drop trap. We just established that the diabetic mom has high blood sugar, so her baby has been swimming in a high sugar environment for months. Why on earth is the priority nursing action to monitor the newborn for low blood sugar immediately after birth? If the mom is hyperglycemic, wouldn't the baby be born hyperglycemic?
This trips up nursing students all the time because they follow the logic halfway. They think, mom has high sugar, baby gets high sugar, but they forget the actual mechanism of birth. Do not confuse maternal hyperglycemia with neonatal hypoglycemia. Let's walk through the timeline.
Okay, walk me through it.
In utero, the fetus was producing massive amounts of its own insulin to deal with the mother's constant sugar supply.
Right, the fetal pancreas is basically bodybuilding, pumping out tons of insulin.
Exactly. Now, the moment of birth happens, the baby is delivered, and the umbilical cord is clamped and cut. In that split second, the massive maternal glucose supply is instantly, permanently cut off.
But the baby's pancreas doesn't know the cord was cut.
Precisely. The fetal pancreas is still operating on the assumption that a sugar avalanche is coming. So the neonatal insulin levels remain incredibly high, but the sugar supply is suddenly gone.
Oh, wow.
The result, that excess insulin rapidly drives whatever glucose is left in the newborn's blood straight into the cells. The neonatal blood sugar absolutely plummets.
Wow. That is a massive crash.
A profound crash. You will see severe neonatal hypoglycemia. As a nurse, you are watching this newborn like a hawk for signs.
What are the signs we're looking for?
You're looking for lethargy, apnea, or paused breathing, a high-pitched cry, temperature instability, and a very specific jitteriness or tremors. If it's not caught and treated quickly with early feeding or IV glucose, it leads to neonatal seizures and permanent brain damage.
That makes perfect sense when you map out the why. Like, you aren't just memorizing a symptom, you're watching a physiological event unfold. Let's cement this with a simple memory anchor. High sugar in the mom equals a big baby and low sugar at birth. High pressure in the mom equals a small baby due to poor perfusion.
That is the perfect way to distill it. If you are taking notes, here are the core takeaways from the giants of high-risk OB. Preeclampsia physically limits placental perfusion by damaging blood vessels. If you leave preeclampsia untreated, the brain swells until the client has eclamptic seizures. On the other side, maternal diabetes causes fetal macrosomia because insulin is a growth hormone. Polyhydramnios is directly linked to diabetes because the hyperglycemia makes the fetus urinate excessively into the amniotic sac. And finally, always watch for neonatal lethargy, apnea, or jitteriness. These are the classic, highly testable signs of neonatal hypoglycemia in an infant born to a diabetic mother.
All right, we have thoroughly covered the internal chronic illnesses that a mother might bring into a pregnancy. But what happens when the threat comes from the outside?
the external threats.
Yeah. Well, let's talk about environmental hazards, teratogenic substances, and psychosocial risks.
Yeah.
And I have to ask, everyone knows smoking is bad for a developing baby. That's just common sense.
Right.
But when you look at exam study guides, you see some really weird specific warnings. Why is a leftover turkey sandwich or a cat litter box suddenly treated like a mortal enemy to a pregnant patient?
I know, it sounds completely bizarre and arbitrary until you look at the microbiology. These are external environmental threats that have the specific ability to cross the placental barrier, which is normally, very good at keeping pathogens out. Let's start with the cat litter box. We're talking about toxoplasmosis.
What exactly is toxoplasmosis? Is it a bacteria?
It's actually a protozoan parasite, Toxoplasma gondii. It reproduces in the intestines of infected cats, and the eggs are shed in feline feces. But it is also commonly found in contaminated garden soil, unwashed raw produce, and raw or undercooked meat from animals that grazed on contaminated soil.
And what does this parasite do if it actually gets across the placenta?
Well, if a pregnant client contracts toxoplasmosis, especially early in the pregnancy, it targets the developing fetal neural tissue. It can cause severe neonatal complications, specifically chorioretinitis, which leads to blindness, profound deafness, microcephaly, and severe cognitive disabilities.
So a simple chore like cleaning a litter box can cause permanent fetal brain damage.
Yes, which is why the priority nursing action, the patient education, is so vital. You must instruct the client to delegate litter box duties to someone else entirely.
Just don't do it.
Exactly. And if they must garden, they have to wear thick gloves to avoid soil contact with their hands, and they must wash all produce meticulously.
Okay, what about the turkey sandwich? The deli meats. I hear pregnant women lamenting all the time that they just want a cold-cut sandwich.
That restriction is all about Listeria monocytogenes. Listeria is a very hardy, harmful bacteria found in unpasteurized foods, soft cheeses like brie or feta, and processed deli meats. Unlike most bacteria, Listeria can survive and even multiply at refrigerator temperatures.
Oh, so keeping the turkey cold doesn't make it safe.
Not at all. And the insidious thing about Listeria is that in a healthy adult, it might just cause a mild flu-like illness or a stomach ache. The mother might barely notice she's sick.
But for the baby...
For the baby, it's devastating. Listeria aggressively crosses the placenta. It can cause overwhelming fetal sepsis, meningitis, and frequently leads to spontaneous abortion or stillbirth.
That is terrifying. So the rule is absolutely no deli sandwiches for 9 months.
Not necessarily, and this is a great nuance for clinical practice. The priority education here is that the client can consume deli meats or hot dogs, but they must be heated until they are literally steaming hot. Heat kills the Listeria bacteria. So a cold turkey sandwich is a massive risk, but a steaming hot turkey panini is safe.
Okay, good to know. Let's talk about another environmental hazard mentioned in our sources, lead exposure. We do not hear about lead poisoning as much these days. It feels like a 1970s problem, but it is still a massive risk in OB nursing.
It absolutely is, and it's deeply tied to socioeconomic status and living environments. We are talking about clients living in homes built before 1978 with chipping lead paint, drinking from old lead pipes, or living near regional airports where aviation fuel still leaves lead in the surrounding soil.
Right.
But here's the most fascinating and frankly terrifying physiological aspect of lead in pregnancy. The danger doesn't just come from what the mother is exposed to today.
Wait, what do you mean?
If a client was exposed to lead at any point in their past, say, during their own childhood, that lead accumulates and is permanently stored in their bones. Now, fast forward to their pregnancy. The developing fetus requires massive amounts of calcium to build its skeleton.
So the mother's body starts breaking down her own bone to give calcium to the baby.
Exactly. The maternal bone remodeling process accelerates to meet the fetal calcium demand. And as the bone breaks down, it releases that decades-old stored lead right back into the maternal bloodstream.
Wow, so past childhood exposure becomes a present danger to the fetus. That is wild.
Yes. And the lead crosses the placenta effortlessly. It competes with calcium in the developing fetal brain, causing severe damage to the nervous system and the developing fetal kidneys. This leads to profound, irreversible neurocognitive impairment, lower IQ, and severe behavioral problems later in the child's life.
What about substances and mental health? Obviously, these are psychosocial factors, but they have direct, measurable biophysical impacts on the pregnancy.
They do, and they are incredibly testable. Let's look at nicotine first. Nicotine, whether delivered via traditional combustible tobacco or a modern vape pen, is a potent vasoconstrictor.
It's basically doing the same thing as hypertension kinking the hose.
Exactly. It clamps down the blood vessels in the placenta, drastically decreasing fetal oxygenation. Furthermore, if the client is smoking combustible cigarettes, they're inhaling carbon monoxide.
Right, which is toxic.
Extremely. Carbon monoxide actually has a higher affinity for hemoglobin than oxygen does, so it binds to the maternal and fetal red blood cells, physically blocking oxygen from being carried to the tissues.
The baby is suffocating on a cellular level.
Yes. Smoking during pregnancy is directly linked to sudden unexpected infant death, or SUI, severe low birth weight, preterm birth, and structural anomalies like neonatal cleft lip. And post-birth, the newborn can experience neonatal abstinence syndrome. They literally go through nicotine withdrawal.
And mental health. I feel like in obstetric nursing, we often focus so heavily on the physical body, the uterus, the blood pressure, that we forget the mother's brain.
It's a huge blind spot, which is why it's a priority focus now. Up to 20% of pregnant clients experience perinatal anxiety or depression. When a client is chronically stressed or severely depressed, their body is flooded with high levels of cortisol, the stress hormone, which can trigger premature labor. Untreated depression leads to a devastating cascade of risks: preterm birth, low birth weight, and decreased adherence to prenatal care.
Right. I mean, if a client is severely depressed, they simply might not have the executive function to show up for appointments, or their nutrition might suffer.
And after birth, it can severely impair mother-infant attachment, leading to failure to thrive for the infant. This highlights why all of this matters so much for the nurse. These are largely modifiable risk factors. You can't unbreak a pelvis, but you can teach someone how to avoid listeria. Patient education and screening here are literally life-saving.
That is the core of the nurse's role.
Yeah.
It isn't just taking blood pressure, it's the conversation.
You must screen for mental health, tobacco use, and substance abuse at every single encounter, and you must do it non-judgmentally.
That's so important.
It's everything. If you walk into a room and use a harsh tone, or your body language shows disgust because a pregnant client smells like smoke, that client will shut down. They will stop being honest with you. Or worse, they will stop coming to their prenatal visits entirely. Your judgment could literally cost that baby its life by driving the mother away from medical care.
That is a sobering reality. Let's run through a rapid fire of expected versus concerning findings for these external threats to take our clinical judgment. A pregnant client tells you they drink a cup of coffee every morning to get going. Expected or concerning?
Expected. The current clinical guideline is that up to 200 milligrams of caffeine a day is generally safe. That equates to about one standard 8-ounce cup of home-brewed coffee.
Okay, what if they're working night shifts and drinking a couple of large energy drinks to stay awake?
Highly concerning. Energy drinks are dangerous in pregnancy because they have wildly varying, unregulated amounts of caffeine, plus massive excess sugar and herbal supplements that have never been tested for teratogenic effects. High caffeine intake constricts blood vessels, limiting oxygen and nutrients to the fetus, directly leading to fetal growth restriction.
What about a client who proudly tells you, I know smoking is bad, so I quit cigarettes. I'm just vaping now, so it's safe for the baby?
Concerning. And this is a massive modern exam trap. Instructors love testing this because vaping is so prevalent. Do not ever let a client assume vaping is a safe alternative. It still delivers concentrated nicotine, which causes the exact same vasoconstriction and oxygen restriction as smoking. Plus, the aerosolized chemicals carry their own unknown risks.
What if a client in their first trimester says they like to relax in a hot tub for an hour every night to ease their back pain?
Highly concerning. The use of saunas and hot tubs, especially in the first trimester, raises the maternal core body temperature above 101 degrees Fahrenheit.
Why is that heat so dangerous? It's just a bath.
Because the first trimester is when organogenesis occurs, the organs are forming. Specifically, around days 21 to 28, the fetal neural tube is attempting to close to form the brain and spinal cord. Maternal hyperthermia disrupts cell division and protein function, and it is directly linked to an increased risk of severe birth defects, particularly neural tube defects like spina bifida.
That is wild. A hot bath can stop the spinal cord from closing. Okay, what about exercise? We're always told that pregnant women should stay active. What if a client wants to start a rigorous running program?
This is another top exam trap. If you think all exercise is universally good for all pregnant clients, you will get the question wrong. While generally encouraged for healthy pregnancies, physical activity is strongly contraindicated if the client has a history of preterm labor, cervical insufficiency, or placenta previa.
Let me make sure I understand why. Placenta previa is when the placenta implants low and covers the cervix, right?
Exactly. If the placenta is covering the exit, or if the cervix is weak and prematurely dilating, putting repetitive physical stress and gravity on the body by running or doing heavy lifting is incredibly dangerous. It can provoke massive, life-threatening hemorrhage or premature birth.
Okay, so if I'm studying this tonight, the biggest traps are assuming vaping is safe, assuming any amount of caffeine is fine, and thinking exercise has no contraindications. The memory anchor from our sources is perfect. No hot tubs, no cold cuts, no cat boxes.
That is a great hook. To summarize the absolute highest yield points here, heat deli meat until it is steaming to kill listeria. Toxoplasmosis hides in litter boxes, and unwashed produce wear gloves and delegate the chores. Keep caffeine under 200 milligrams a day to ensure the baby grows properly. Avoid hot tubs in the first trimester to prevent neural tube defects. And remember that both vaping and smoking restrict oxygen and cause low birth weight. Neither is a safe option.
All right, moving forward. We know the internal risks like diabetes and the external risks like listeria. But how do we actually test for all of this? And I have to complain for a second because obstetric nursing seems to pride itself on having way too many acronyms. We have CVS, AFP, PPPA, RHG, NST, CST, BPP. It is an absolute alphabet soup.
It is incredibly intimidating when you first look at it, but we're going to break these down chronologically. These tests are the roadmap of a pregnancy. They reveal severe genetic anomalies, structural defects, or life-threatening blood incompatibilities.
Let's start at the beginning. First trimester. What are the big tests?
The first major diagnostic procedure is CVS, or chorionic villus sampling. This is done very early, usually between 10 and 13 weeks of gestation.
What exactly are they sampling?
The chorionic villi are tiny, finger-like projections of placental tissue that share the baby's exact genetic makeup. A needle is inserted either through the abdomen or the cervix to snip a tiny piece of this tissue for genetic karyotyping. Because it is an invasive procedure happening very early while the pregnancy is still fragile, there are significant risks: bleeding, infection, premature rupture of membranes, and pregnancy loss.
And there's a non-invasive ultrasound test done in the first trimester too, right?
Yes, the fetal nuchal translucency ultrasound, usually done between 11 and 13 weeks. The ultrasound tech specifically measures the fluid collection at the back of the fetal neck.
Why the neck?
In fetuses with certain chromosomal anomalies, particularly trisomy 21 or Down syndrome, there is a delay in the development of the lymphatic system. This causes lymphatic fluid to back up and pool at the nape of the neck. If the ultrasound shows an increased, abnormally thick measurement of fluid there, it is highly associated with trisomy 21.
Okay, that makes so much sense. Now let's move into the second trimester. We have amniocentesis.
Correct. Amniocentesis is an amniotic fluid draw. A long needle is inserted through the maternal abdomen, guided by ultrasound, directly into the amniotic sac. It collects fetal skin cells and waste products floating in the fluid. Like CVS, it is a diagnostic test to definitively confirm genetic or inherited anomalies.
Why do an amnio if they already did a CVS?
Timing and fluid volume. You can't do an amnio at 10 weeks because there isn't enough amniotic fluid. The needle would likely injure the fetus. You wait until 15 to 20 weeks for an amnio.
And then we have the maternal blood tests, the AFP and the quad screen.
The quad screen is performed between 16 and 18 weeks. It tests the mother's blood for 4 specific markers: alpha-fetoprotein, or AFP, human chorionic gonadotropin HCG estriol, and inhibin A.
Let's talk about the exam traps here, because I know from personal experience that instructors love to test the quad screen.
The biggest, most dangerous trap here is the screening versus diagnostic trap. You absolutely must know the difference. The AFP and quad screens are screenings. They only indicate risk or probability. They do not diagnose a disease.
Let's play that out. What does AFP actually measure?
AFP is basically the fetal version of albumin, a protein made in the fetal liver. Normally, a tiny amount crosses into the amniotic fluid and then into the mother's blood. But if the fetus has an open neural tube defect, like spina bifida, where the spine hasn't closed, massive amounts of this protein leak out of the open wound into the fluid, and maternal blood levels skyrocket.
So a high AFP level suggests a risk for a neural tube defect.
Exactly. But it only suggests a risk. It could also just mean the mother's due date is wrong or she is carrying twins. You cannot diagnose a fetus based on a quad screen.
So if a patient calls in a panic because their screening is positive, what is the priority nursing action? You can't just say, well, your baby has spina bifida.
Never. Your priority action is to provide calm education, emotional support, and refer them for diagnostic testing. You tell them this test just means we need to take a closer look. You then prepare them for a targeted high-resolution ultrasound or an amniocentesis. Amnio and CVS give you a definitive karyotype. They are diagnostic.
Okay, let's talk about expected versus concerning findings with these obscure acronyms. PPA is one that shows up a lot. Pregnancy-associated plasma protein A.
PPA is an enzyme produced by the trophoblast, the outer layer of the early placenta. You want expected normal levels of PPA because it indicates the placenta is implanting and functioning well. Low levels of PPA are highly concerning.
Why? What does it mean?
Low levels mean the placenta is failing at a cellular level. It directly correlates with poor pregnancy outcomes later on, fetal demise, severe growth restriction, preeclampsia, and it's also a marker for genetic anomalies like trisomy 13, 18, and 21.
Another priority nursing action regarding these tests, especially the ultrasounds and amniocentesis, is bladder management. It sounds so basic, but it's constantly tested.
Yes. Always ensure the patient has the appropriate bladder status based on gestational age and the procedure. For early first trimester abdominal ultrasounds, you want the client to have a completely full bladder. The full bladder acts as an acoustic window and literally pushes the small uterus up out of the pelvis so the ultrasound waves can see it.
But for an amnio later in pregnancy?
You want an empty bladder. By 20 weeks, the uterus is high enough, and a full bladder would just be in the way of the needle, risking a bladder puncture. And post-procedure for an amnio or CVS, the nurse's priority is strict monitoring for vaginal bleeding, fever, or signs of infection, and premature rupture of membranes. You are watching to ensure the invasive needle didn't trigger a miscarriage.
Okay, we need to talk about the blood typing test because this is historically one of the most confused, twisted topics in OB nursing. The Coombs test and RH incompatibility.
This is a guaranteed exam question on every single nursing board exam. Let's break it down to its physiological roots. The Coombs test checks for antibodies in the maternal blood that are designed to attack red blood cells. We are specifically looking at the Rh factor, the positive or negative sign on your blood type. Every pregnant client gets an indirect Coombs test.
What is the expected happy finding?
The expected finding is a negative Coombs test. It means the mother's immune system has not developed antibodies against Rh-positive blood.
And the concerning finding?
A positive Coombs test. This is bad. This means the mother is sensitized. She has formed permanent antibodies that will cross the placenta and attack the red blood cells of an Rh-positive fetus. This causes severe fetal hemolytic anemia, where the baby's blood cells literally burst, leading to profound jaundice and potentially fatal heart failure in utero.
So how do we prevent this immune system warfare? This is where the medication RHIG comes in, right? Ro. Immune globulin, often known by the brand name Rojam.
Yes. And here is the massive, bold print Rh trap on exams. RIG is given to Rh-negative mothers only. Never, ever give Rh-negative mother. An Rh-positive mother already has the Rh protein. Her body will never make antibodies against it.
Okay, so if I have an Rh-negative mother, when do I give her this injection?
You give it prophylactically at 28 weeks of gestation. And then you give a second dose within 72 hours after birth, but only if the newborn is tested and confirmed to be Rh positive.
And here is the mind-blowing part, that students always trip over this medication. It doesn't really protect the current baby in the uterus, right? I always thought it was like a shield for the baby she's currently carrying.
That is the ultimate misconception. Let's look at the biology. If the mother is Rh negative and her first baby is Rh positive, their blood doesn't usually mix during the pregnancy. The placenta keeps them separate. But during the trauma of birth or during a miscarriage or an amniocentesis, fetal blood cells inevitably spill into the mother's bloodstream.
And the mother's immune system sees those Rh-positive cells as a foreign invader.
Exactly. Her immune system sounds the alarm and creates permanent IgG antibodies to destroy them. But by the time her body manufactures those antibodies, that first baby is already born and perfectly safe in the nursery.
But the mother is now permanently armed.
Yes. She is sensitized. If she gets pregnant again a year later with another Rh-positive baby, those pre-made antibodies will immediately cross the placenta and aggressively attack the second baby. RHIG is passive immunity. It is a dose of synthetic antibodies that circulates in the mother's blood and quietly sweeps up and hides any stray fetal red blood cells before her immune system ever notices them.
So it stops her from ever forming her own permanent antibodies. It protects her future pregnancies.
Exactly. It is entirely about protecting the next baby.
That is so clearly explained. Let's lock this in with memory anchors. Rh negative needs the needle. That reminds you exactly who gets the RHE. And for the early procedures, C comes before A in the alphabet, just like CVS comes before amnio in the pregnancy timeline. CVS is first trimester, amnio is second.
Excellent. So if I'm highlighting my notes, the traps to avoid are AFP is just a screening, not a diagnosis. CVS is done early but carries higher risks of disrupting the pregnancy. Neutral translucency screens for trisomy 21 by looking at lymphatic fluid on the neck. A positive Coombs test is a dangerous finding. It means the mother is sensitized. And ARCAG is only for Rh-negative moms to protect their future babies.
We are building a really solid foundation here. Let's move to the next phase. We have run all the early labs, we check the genetics, we check the blood types. But fast forward to the third trimester. How do we know if the baby is safe right now?
That is the entire purpose of fetal surveillance. These tests generally begin around 32 weeks for high-risk clients. They give the care team a real-time snapshot to answer a crucial question: is this fetus thriving or is the placenta failing, meaning we need to intervene and deliver immediately?
I have an analogy for the two main monitor tests. Tell me if this works clinically. A non-stress test, or NST, is like checking the baby's resting pulse while they're just chilling on the couch. A contraction stress test, or CST, is like putting the baby on a treadmill to see if their heart fails under the pressure of a heavy workout.
That is a brilliant clinical way to view it. But before we get to the monitors, let's start with the absolute simplest zero technology surveillance kit counts, or daily fetal movement counts.
The pregnant client does this at home. What is the standard we teach them?
We want to see 10 distinct movements in a 2-hour window. Why? Because fetal movement is a direct physiological indicator of fetal central nervous system integrity and oxygenation. A fetus that is well oxygenated has the energy to move. A hypoxic fetus will conserve energy and stop moving.
So if a patient calls triage and says, my baby hasn't moved much today, I've only felt 3 kicks, what is the priority nursing action? Do we tell them to rush to the OR?
You do not panic immediately, but you absolutely take action. The fetus might simply be in a deep sleep cycle, which usually lasts 20 to 40 minutes. Instruct the mother to drink something cold and sweet like juice, eat a small snack, or take a brisk walk to wake the baby up and then lie on her side and count again. If there is still insufficient movement after those interventions, they must report to the clinic or triage immediately for an NST.
Okay, let's look at the baby on the couch, the non-stress test. What is the high-yield core here?
The NST uses an external electronic fetal monitor strapped to the mother's abdomen. We are evaluating the fetal autonomic nervous system. When a healthy baby moves, its sympathetic nervous system causes the heart rate to temporarily accelerate, just like your heart races when you stand up quickly. We are looking for a reactive strip.
What makes it officially reactive?
To be considered reactive and reassuring, we want to see at least 2 accelerations in the fetal heart rate, rising at least 15 beats above the baseline and lasting for at least 15 seconds, all within a 20-minute window. We call this the 15 by 15 rule.
What if it is non-reactive? I'm watching the monitor for 20 minutes, and the heart rate is just a flat line. No accelerations. Is the baby dying?
Not necessarily. Again, they might just be sleeping. You can try vibroacoustic stimulation, which is basically placing an artificial larynx or a buzzer on the mother's belly to startle the baby awake. But if the strip remains non-reactive after 40 to 60 minutes despite stimulation, it is highly concerning. It presumes the fetus is compromised and hypoxic. The priority action is to immediately escalate to a biophysical profile, or BPP.
Let's define the BPP. It sounds comprehensive.
A BPP combines the NST with a detailed ultrasound. It evaluates 5 variables, scoring each one with either a 2 for normal or a 0 for abnormal. The maximum score is 10. The variables are the NST results, amniotic fluid volume, fetal breathing movements, gross body movements, and fetal muscle tone.
Why do we care about tone versus breathing? Don't they all just mean the baby is moving?
This is a beautiful piece of physiology. The fetal brain centers develop at different gestational ages, and they shut down in response to hypoxia in the reverse order of their development. Fetal breathing is a complex, recently developed reflex. It's the first thing to stop when oxygen drops, because the baby is conserving energy. Fetal tone, the ability to keep the limbs flexed, is a primitive brainstem reflex. If the baby has lost fetal tone and is completely flaccid, it means the hypoxia is severe and late stage.
So expected versus concerning for the BPP.
An 8 to 10 is reassuring. A score of 6 means equivocal, monitor closely. A score of 4 or less is highly concerning. It indicates severe, acute fetal hypoxia, and the team must prepare for immediate delivery, likely via cesarean.
Now let's talk about the treadmill test, the contraction stress test.
A CST evaluates how the fetus will tolerate the massive physiological stress of labor. During a contraction, the uterine muscle bears down and literally squeezes the spiral artery shut, temporarily cutting off oxygen to the placenta. A healthy, robust placenta has enough respiratory reserve to handle this temporary squeeze. A failing placenta does not.
How do we do a CST if the mother isn't in labor?
We induce contractions either by administering intravenous oxytocin or by having mother perform nipple stimulation, which releases endogenous oxytocin. We need 3 contractions in a 10-minute window.
And here is the positive-negative word trap that instructors absolutely love to use to fail students. This is crucial for exams.
Yes, listen carefully to this. In normal medical terminology, hearing a test is positive usually means you have a disease, you test positive for strep throat, that's bad. But for a CST, a positive test is profoundly BAD. It means the baby had a positive reaction to the stress, which manifests as late decelerations. The baby's heart rate dropped after the contraction peaked, meaning the placenta failed to provide enough oxygen.
And a negative CST.
A negative CST is good. It means there were no late decelerations. The baby tolerated the stress perfectly.
And for the NST, we don't use positive or negative, right?
Correct. For an NST, we want a reactive result. So the memory anchor you must memorize is positive stress is bad stress for the CST, and reactive is reassuring for the NST.
I love that. So summarizing our surveillance traps, 10 kicks in 2 hours is the standard. A reactive NST requires the 15 by 15 rule. A positive CST is a critical failure indicating hypoxia. A BPP scores 5 variables out of 10, and a score of 4 or less means we are heading to the OR immediately.
Exactly.
Let's shift gears slightly. We have talked about the placenta, the genetics, the heart rate. But what happens when the protective bubble around the baby, the amniotic fluid itself, goes wrong? We are talking obstetric complications and fluid volume disasters.
Amniotic fluid is not just water. It is a highly dynamic, essential fluid. It acts as a physical cushion. It allows for symmetrical musculoskeletal growth because the baby has room to stretch. It prevents the umbilical cord from being pinched, and it maintains a stable temperature. When the volume is abnormal, it is a huge red flag for underlying pathology.
Let's define the 2 extremes, oligohydramnios and polyhydramnios.
Oligohydramnios means severely decreased fluid volume. This is highly concerning. It is often caused by maternal hypertension, causing placental insufficiency, or by fetal renal anomalies, like renal agenesis, where the kidneys don't form.
Wait, why do fetal kidneys dictate the fluid volume?
Because, as we discussed with diabetes, in the second half of pregnancy, amniotic fluid is predominantly fetal urine. The baby pees it out, then swallows it, then pees it out again. It's a continuous cycle. If the fetal kidneys are failing or absent, urine production drops and fluid volume plummets.
And what is the immediate life-threatening risk with low fluid?
Cord compression. Without that generous fluid cushion, the fetus can easily shift and pinch the umbilical cord between its body and the rigid uterine wall. This instantly cuts off the fetal oxygen supply, which you will see on the monitor as variable decelerations.
What about polyhydramnios? Too much fluid.
We covered one cause earlier, maternal diabetes, causing fetal polyuria, but it is also heavily linked to fetal gastrointestinal anomalies, like a tracheoesophageal fistula or esophageal atresia. In these conditions, the fetal esophagus doesn't connect to the stomach properly, so the fetus cannot swallow the fluid to regulate the volume. They keep peeing, but they can't drink, so the fluid builds up massively.
And what is the risk for the mother having 2 gallons of fluid in her uterus?
An overdistended uterus. When you stretch the uterine muscle fibers at far beyond their normal capacity, they lose their elasticity. After the baby is born, that stretched out muscle has a very hard time clamping down and contracting. This severely increases the risk for uterine atony and life-threatening postpartum hemorrhage.
Okay, let's talk about the membranes breaking, the water breaking. We have PROM and PPROM. What is the difference and what is the exam trap here?
PROM stands for pre-labor rupture of membranes. The water breaks before the onset of true labor contractions, but the pregnancy is at term 37 weeks or more. PPROM is preterm pre-labor rupture of membranes. The water breaks early, before 37 weeks.
Why does it matter so much if the water breaks early?
Because the moment that amniotic sac ruptures, the sterile intrauterine environment is completely compromised, the protective seal is gone. The biggest risk is an ascending bacterial infection called chorioamnionitis. It can cause overwhelming maternal sepsis and fetal pneumonia. Therefore, the priority nursing action with suspected PROM or PPROM is strict, frequent monitoring of the maternal temperature and vital signs, and avoiding unnecessary vaginal exams that could push bacteria upward.
But practically speaking, if a patient comes to triage and says, I think my water broke, but I might have just peed myself, how do we know it is amniotic fluid?
That is a crucial nursing assessment. You must test the fluid. You can look at a swab of the fluid under a microscope. Amniotic fluid contains sodium chloride, and when it dries on a slide, it crystallizes and looks exactly like a fern leaf. We call it ferning. Or more commonly, you use nitrazine pH paper.
And here is the pH exam trap. I remember getting this wrong in school.
Yes. Normal vaginal secretions are naturally acidic to prevent infection. Amniotic fluid is alkaline. Nitrazine paper turns deep blue in the presence of an alkaline fluid. So the memory trick is blue equals amniotic. If the paper stays yellow or olive green, it is just acidic vaginal fluid or urine, and her water has not broken.
Let's discuss one more complication from the sources that sounds incredibly obscure, but is highly tested on the NCLEX cholestasis of pregnancy.
It is intensely testable because the presentation is so unique. The pregnant client will complain of intense, severe itching pruritus. But here's the key. The itching is specifically located on the palms of their hands and the soles of their feet, and it is usually much worse at night. The absolute crucial detail to look for in an exam question: there is NO rash.
If there's no rash, what is happening internally to cause the itching?
It is a liver issue. Due to hormonal changes, the flow of bile from the maternal liver is diminished. Bile acids back up and accumulate in the maternal bloodstream, causing the intense peripheral itching.
And why is this an obstetric emergency requiring an immediate report to the provider? It's just itching, right?
For the mother, it's just miserable itching, but for the fetus, it is lethal. Those high circulating bile acids cross the placenta and are incredibly toxic to the fetal heart. Cholestasis carries a very high sudden risk of intrauterine fetal demise due to cardiac arrhythmias, as well as preterm birth and meconium aspiration.
So what are the priority actions if a patient reports itchy palms?
You immediately draw labs to monitor the maternal total bile acid levels and liver enzymes. You anticipate an order for a medication called ursodeoxycholic acid, or UDCA, which helps bind and lower the bile acids. And you prepare the patient for frequent fetal surveillance, likely biweekly BPPs, and almost certainly an early induction of labor to get the baby out before the bile acids cause cardiac arrest.
Let's anchor this segment. Polyhydramnios equals much fluid, much sugar, pointing to diabetes and hemorrhage risk. Oligohydramnios equals little fluid, pointing to poor perfusion and cord compression.
Spot on. And for the exams, remember PROM and pre-PROM require immediate strict monitoring for maternal temperature spikes. Nitrazine paper turning blue confirms membranes have ruptured because amniotic fluid is alkaline. And severe itching on the palms and soles without a rash equals cholestasis, which you must report immediately due to the high risk of sudden fetal demise.
All right, we have reached the culmination of all this data. We have armed our listener with the high-yield facts, the intricate pathophysiology, and the glaring red flags. But how does a nursing student actually apply this on a brutal exam or in a chaotic clinical setting? Let's bring it back to the absolute core of nursing, the clinical judgment model.
Exams like the NCLEX have evolved. They do not just ask you to regurgitate a definition of preeclampsia anymore. They give you a complex, messy scenario and ask, what will the nurse do first? Or which of these 4 patients do you see first? They are strictly testing your clinical judgment using the assessment, analysis, planning, implementation, and evaluation model.
Let's run a scenario using telehealth, since our sources heavily emphasized how vital telemedicine has become for managing high-risk OB clients. Imagine you are the triage nurse. A 32-week pregnant patient calls the clinic via telehealth and says, I feel really puffy today, my head is pounding, and I have this weird pain right under my ribs on the right side. How do we prioritize that using the nursing process?
Step 1 is to recognize cues. This is your assessment phase. You hear puffy, head pounding, and right upper quadrant pain. Are these expected biophysical changes, or are they red flags?
Based on what we discussed earlier, mild puffiness might be expected, but a pounding headache means cerebral edema, and that right upper quadrant pain, wait, what does that pain mean?
That is a classic cue for severe preeclampsia progressing to HLLP syndrome. The liver capsule is swelling and distending, causing pain on the right side. So you have recognized the cues. Step 2, analyze and prioritize. Is this an airway, breathing, or circulation issue?
Yes, severe hypertension affects circulation in the brain and the liver.
Exactly. The priority here goes entirely to the mother's safety. She is at imminent risk for an eclamptic seizure or liver rupture.
Which brings up a great fundamental memory anchor for all OB prioritization questions. Mom's safety secures the baby's safety. You cannot save a hypoxic fetus if the mother's physiology completely collapses.
Always. You prioritize maternal physiological stability first. Now, steps 3 and 4, generate solutions and take action. On a telehealth call, your action cannot be administer intravenous labetalol. You aren't there. Your action is to direct them to immediately go to labor and delivery triage for evaluation, or call an ambulance if the symptoms are severe enough.
And let's talk about the biggest, most consistent exam trap when it comes to the nursing process.
Choosing an intervention before completing an assessment. This fails students constantly. If an exam question says, a pregnant client reports decreased fetal movement, and one of the multiple choice answers is, prepare the client for a stat cesarean section, that is wrong. You do not intervene with major surgery before you assess the situation. The correct answer will always be something like, apply the external fetal monitor to assess the fetal heart rate. Always recognize cues and assess first, unless the scenario describes an obvious, active, life-threatening emergency like a visible hemorrhage or an active seizure.
Telehealth isn't just for triaging emergencies, though. It's also huge for addressing sociodemographic factors, right? Because the data shows that delayed prenatal care drastically increases the risk of stillbirth.
Yes, profoundly. Lack of reliable transportation, lack of childcare for older siblings, living 2 hours away from a high-risk clinic. These are massive systemic barriers to care. Telehealth bridges that gap. It allows for home monitoring of blood glucose for our diabetic clients and home blood pressure monitoring for our hypertensive clients. It keeps them in the system, which directly reduces neonatal mortality.
And the nurse's personal attitude plays a critical role here, too, especially with vulnerable populations.
An absolutely critical role. A concerning finding during an assessment isn't just a physical symptom, it's also a patient skipping appointments. If a nurse is overtly judgmental, if they lecture a client about their weight, scold them for substance use, or show frustration over a lack of health literacy, that client will shut down and simply not return. A non-judgmental, active listening approach from the nurse directly impacts whether a high-risk patient receives the continuous life-saving care they need. Your empathy is quite literally a clinical intervention.
That is a powerful way to frame it. Empathy as an intervention.
It truly is. So for clinical judgment, remember, always assess and recognize cues before you take action. Prioritize maternal physiological stability to ensure fetal stability. Telehealth is a valid ACOG-endorsed tool for high-risk monitoring, and the nurse's non-judgmental attitude directly impacts patient adherence and survival.
We have covered a truly tremendous amount of ground today. We have waded deep into the muddy waters.
We really have. We've gone from the cellular level of insulin resistance all the way to systemic telehealth protocols.
Let's do a quick conversational summary to lock it all in for the listener before their exam. High blood pressure kinks the hose, damaging the placenta, leading to small babies and preeclampsia. And we're watching like hawks for headaches and vision changes.
And high blood sugar acts like sludge, leading to big babies and polyhydramnios. But remember, the trap watch for severe neonatal hypoglycemia when that umbilical cord is cut and the sugar supply crashes.
Toxoplasmosis hides in the litter box, listeria hides in cold deli meats, and hot tubs in the first trimester will halt the neural tube from closing.
For the alphabet soup, CVS is done early and is diagnostic. AFP is merely a screening for neural tube defects, not a diagnosis. RHIG is for Rh-negative mothers only, and it functions to protect their next baby from immune attack.
Reactive NSTs mean the baby is autonomic and happy. Positive CSTs are terrible news. The baby is failing under the stress of contractions. Oligohydramnios leads to cord compression. Nitrazine paper turns blue for amniotic fluid. And severe itching on the palms without a rash means cholestasis, which requires immediate intervention.
And through it all, always assess first. Mom's safety secures the baby's safety.
As we wrap up this incredibly deep dive, I want to ask you for a final thought. We've talked so much about complex pathophysiology, fetal surveillance monitors, lab values, and diagnostic acronyms.
We have, and as a future nurse, you need all of that science. But I want to leave you with a thought regarding the true art of obstetric nursing. We rely so heavily on ultrasounds to see the unseen inside the uterus. We rely on blood draws and amniocentesis to tell us the exact chemical and genetic balance. The technology is genuinely amazing.
It is. It saves lives every day.
It does, but never, ever underestimate the diagnostic power of simply listening to a mother. When a pregnant client looks at you and says, "Something doesn't feel right, the baby feels different," or "I just feel off." In a landscape of diagnostic muddy waters, a mother's intuition is often the very first and most accurate clinical cue we ever get. Long before the blood pressure spikes on the cuff, long before the electronic monitor shows a late deceleration, the mother often knows.
So when that metaphorical X-ray machine is broken and the waters are murky, let the mother's voice be your compass. Listen to her.
Exactly. Let her guide your assessment.
To our listener, take a deep breath. You are not just memorizing flashcards.
Yeah.
You are learning how to save lives. You have the tools, you understand the deep physiological patterns, and you are building razor-sharp clinical judgment. You're going to absolutely crush your exams, and more importantly, you're going to be an incredibly safe, phenomenal future nurse.